All right, welcome everybody. We're going to get started on our talk. So first, just some introductions. I'm Cara Grimes, and I'm the Vice Chair of Research and Faculty Development at Albany Medical College, which is in New York. And I'm going to apologize because I'm getting over some laryngitis, but I think I can make it through this. And I'm here today with my colleague, Ben Brucker, and he is the professor both in the departments of obstetrics and gynecology and urology at NYU. And we are both going to welcome you to our talk today. It's Seeing Clearly, Optimizing Ureteral Patency with Diagnostic Dyes.
Yeah, and unfortunately with your laryngitis, I don't know that we're going to be able to do that singing duet at the end of the talk. So for those that signed on for that, we're sorry for that.
All right, we just have to figure out how to advance this. Thank you. So today we're going to focus on something that happens that every gynecologist, urogynecologist, and urologist thinks about, and that is how to evaluate ureteral patency during our surgeries. So often we use intraoperative cystoscopy, and sometimes we just use a cystoscope and we look in and we try to look for our ureteral jets. And our goal really is to detect injuries or obstructions so that we're not leaving the OR that way. Sometimes it can be hard to see the ureteral jet, so there are different agents, specifically dyes, that can change the color, and there's also different installation fluids that can change the density of the ureteral flow that we use to enhance our visualization. So today, we're going to really focus on some of these dyes. We're going to talk about the differences in efficacy, differences in the visualization capabilities, and also the safety profiles of these common dyes that are used to assess ureteral patency. So Ben, we'll start with, at the beginning I mentioned that we use cystoscopy in many of our gynecologic and urogynecologic surgeries to assess ureteral patency. Can you just start by telling us why this is important?
Yeah, so I think, Cara, thanks first of all, and want to thank everyone that signed on tonight. So cystoscopy, I think, and looking for ureters is important for a lot of the surgeries that we do, and even general surgeons do, colorectal surgeons. But in general, ureteral injury can happen. I think this is more of a anatomy thing than necessarily, hopefully, a surgeon thing. But the ureters do find a spot in our pelvis, in the abdomen, and sort of the retroperitoneum that, unfortunately, when there are things that we're doing, hysterectomies, removal of tumors, removal of portions of the different organs, that can be injured. And I think that when it comes to something like a ureteral injury or a bladder injury even, when we have a tool like a cystoscope, it's actually pretty easy to identify if there's something that's going on. And a lot of what we do in urogynecology, for example, and that's a hat that we both share, has to do with the ureters and sort of kinking or blocking of ureters. And so visualizing efflux after a surgery has been completed actually gives us a lot of reassurance that, in fact, things are okay and the patient's not going to have an issue post-operatively. The reason it's so important is there is a lot of morbidity that can come from unrecognized ureteral injuries and bladder injuries, for that matter. And if we identify injury or we identify things like obstruction, it becomes a lot easier for us to actually mitigate the injury. And I think in many cases, we'll talk about it a little later, but something as simple as taking a stitch down or putting a stent in, now this is not a prolonged recuperation and recovery. So I think the injuries can happen no matter who the surgeon or what the surgery is. We have a way of detecting it. And if we detect it and actually do something about it, we can mitigate that injury.
Yeah, I agree with you. I think it's important to be humble and to recognize that injuries or obstructions can occur to any surgeon at any time. And that really the most important thing is that it's in our minds and that we're looking for it. Yeah. So kind of moving along, can you talk about some of the factors that might cause us to miss detecting these ureteral injuries?
Yeah, so I think it is important to realize that a a lot of injuries are not diagnosed intraoperatively, and the numbers suggest maybe half to 70% of ureteral injuries are not diagnosed at the time of surgery. So that means that the patient has a surgery, surgeon thinks everything went well, patient thinks everything went well, and then there's going to be some other event that takes place down the road. There are things that can make it difficult to detect. So, for example, things like adhesion. There is a little bit, you were saying, being humble. If you think, well, the ureter is not there and I'm not going to look for it. I know today doing cases, probably 7 times I looked at the same ureter just because I wanted to make sure that I saw and knew where it was. And still at the end of the case, I checked patency. I think that there are going to be abnormalities. The other day I had a case where there was a duplicated ureter, or there's a case where it's an abnormal course. Maybe there's a mass obstructing, maybe there's some tethering or retroperitoneal fibrosis. And I think, unfortunately, when cases get tough, that's when injuries go up a little bit. So if you have bleeding and you're trying to stop the bleeding, or there's hemorrhage, maybe we're not seeing or visualizing, or maybe we're getting a little more panicked. There are going to be congenital things. And then people that have just had prior surgeries. So, really the take home here is this number should not be 50 to 70%. There are going to be some portion of ureter injuries that we do not identify intraoperatively, but we want to make this number as small as possible. And that's why if we can find these things early and correct them early, it's a lot easier.
Great. I agree. Anything that helps me avoid a complication or detect it and catch it earlier is helpful. So now let's start talking about how we can make cystoscopy easier so that we can evaluate the ureters and see the jets. Can you kind of talk us through the major options that we have that we can use at the time of cystoscopy to help us evaluate ureteral patency?
Yeah. So, I think there are, first of all, people that'll do a cystoscopy and look at a ureter and say, oh, it's peristalsing. I have personally kinked ureters with stitches for prolapse where it peristalses, but it's obstructed. There are stitches that can do that. And then there are times when I think I see efflux, but you don't want to get into that mindset of like, oh, it can't happen to me, or it didn't happen to me. And in my mind, having some agent or some way of increasing the probability of me being sure that efflux is actually efflux is a good thing. Now, you could also argue maybe there are reasons to use other agents that stain the urine, because if you're looking intra-abdominally and let's say there was a transection or a partial injury of a ureter, you might see it. Obviously, there are different reasons to use different agents, but I think I actually learned from you, Cara, to think about this in 3 different classes. We have IV dyes. So these are things that are going to be given intravenously. And then the category of oral agents, so things that a patient will take orally by mouth. And then there are certain cystoscopic fluids that can be used. So those are the 3 big buckets that can be used for abdominal pelvic surgery. We'll go over the agents, but indigo tine disulfate, or indigo carmine is an IV agent. There's sodium fluorescein and methylene blue. I will mention FDA approval for the indigo carmine for this purpose of ureteral patency. Oral agents, I think, became popular when we lost some of the IV agents, and we'll talk about this a little bit, but phasopyridine and riboflavin, just again, advantage, disadvantage, we'll talk in a little, and then the cystoscopic fluids, things that'll change the density so that when the urine jet comes out, we can actually see the optical densities change. So those are the 3 major categories for assessing patency intraoperatively. So if we look at a little bit of a deeper dive into some of these agents, the FDA approval, as I mentioned, for indigo carmine, and it's going to give you a nice deep blue, purplish color. It does come in a 5 ml vial now, and it's easy to remember to give just the whole ampule or 5 mLs if anesthesia asks. Time to visualization, we'll talk a little bit about, but it's under 10 minutes. The half-life is about 12 minutes. Sodium fluorescein is an agent that is also used. This is going to be a yellow or a bright, almost green color. Doesn't necessarily have data for FDA approval for ureteral patency. Again, it's nice that it's a single vial with the time to visualization under 10 minutes, with a little bit of a longer half-life, about 24, 25 minutes. And then methylene blue, which gives really a darker sort of pure blue, sometimes can be a little greenish, 10 milligrams per ml, weight-based dose, with a very long half-life. And those are the basic dyes and the description of those. When we sort of talk about each of these dyes, I think there are some other things that we need to realize that, historically, indigo carmine had been used, and there was actually a shortage of indigo carmine. So I think the whole reason we know all of these other agents, I mean, Cara, we're contemporaries, but when we were training, I don't know that I had ever heard of sodium fluorescein, and these were things that we didn't use. But
we lost carmine.
Exactly. So there was a shortage after basically the issue came that there was no data and no good sort of real medical use for indigo carmine. And the FDA said, look, you can't have an agent that doesn't have approval. And then thankfully, it was reintroduced to the market just a couple of years ago. So in 2022, and now, lo and behold, it's the only agent, indigo carmine, that is in fact FDA approved for this reason. And it's nice because we have a good set of data, so we can talk in an educated way about this agent and why it's useful. Sodium fluorescein used extensively in ophthalmology. That's where I had heard about it. Again, when we didn't have indigo carmine, people found this and loved it. I remember talking with some folks saying, hey, I don't know that I'm going to ever give up sodium fluorescein because it works really quickly and I really liked it. I do notice, and we'll talk about this in the cases that I'll ask you about later, it keeps coming, and it's really in some ways almost like such a good agent dyeing the bladder that, I mean, I've been fooled by sodium fluorescein to think that it was blood coming out of a ureteral orifice, because the whole background is orange and then there's like a darker orange that comes out. So it's great to see the initial flush. But if, let's say, the nurse doesn't have the water set up appropriately, or maybe the cystoscope tray is contaminated, I do worry about ability to see and to look for other things. And then methylene blue, diving a little bit deeper, it is something that, I think can be an okay agent. It's really long half-life, so it takes a while to leave. And there are some, I think, even concerns that we have that we will talk about it in a couple of slides. So just sort of want to take a moment, Cara, and talk to you about some of the other agents. So phasopyridine, you have to give this orally. So there may be an advantage or disadvantage to time that. Many of your patients, I'm sure, NPO, and, it's the timing of, well, the case before took a little longer, was a little shorter. Riboflavin, also an orange yellowish color, can be given orally before surgery. And then the two agents, and I don't really have a lot of experience with them. I mean, I've seen them use dextrose, for example, but that would be something administered in the bladder. And again, it's just a different density than I don't know if you've ever been in a place where you have like salt water and fresh water mixing. It sort of gives this cloudy appearance. Those are from my scuba diving days, but you can see that with dextrose and mannitol. So those are the agents.
Yeah, and I think those are very nice, because if you forget to give something in the pre-op area, or you don't have the dye to give IV and you're waiting for it, these are usually readily available in most ORs. At least the mannitol is, and you can just hang it.
Yeah, no, it is a good agent.
I think we can go to the next slide.
Yeah, can you go back one slide, I think? Yeah.
Yeah. Oh, did you want to say something about this before we move on?
Yeah, no, I didn't. I sorry, I saw the slide move,
okay.
But
yeah, I think it'll lead you into talking about the safety concerns.
Sure. Right. So, I think when it comes to agents that change the color of things, there are things like pulse oxes that can transiently change. So, if you're with an anesthesiologist or anesthesia provider that's not aware, indigo carmine given, let everyone know that the saturation may falsely drop just temporarily. I think sodium fluorescein, also, I don't see it quite as much. I think the big concern, and when we were trying to come up with an agent to use when we didn't have indigo carmine, was methylene blue, and it came up, and it actually, we had a patient where someone noticed this, and it was a big concern, which is you can have serotonin syndrome if you're using methylene blue in combination with serotonergic drugs. So lots of our antidepressant type medications are in that class, and if you look at your patients that you're operating on, it's not uncommon for them to be on these agents. So I do have some concerns. Also, there's reports of hemolytic anemia. So methylene blue, I think, is a concern agent. And really, of the IV dyes, on a personal level, if I had to choose between the three of them, if I have methylene blue, which really lasts a long time, I find it a little slower to kick in. I have sodium fluorescein, which is good, but it's like a mess in the bladder afterward. And then I have indigo carmine, which is FDA approved for this. And indigo carmine really doesn't have any of these safety concerns, and it's been studied for this. I end up choosing, indigo carmine. The other agents, I think, phasopyridine, urine analysis is going to be off by the phasopyridine. So you give it preoperatively, and then some nurse dips the urine and it comes back nitrate positive, and then you cancel a case. And it turns out it was just the phasopyridine that made it. There are actually concerns about G6PD. And also interferes with the sugar analysis. So depending on the timing and what the practice is, or what the OR practice is. And I think riboflavin, which is good. Again, not a lot of experience using it for this, but takes a longer time to change the color. Dextrose, it's been reported an increased risk of UTIs and electrolyte issues if it's absorbed. And then I think also similar electrolyte issues with mannitol. And so when you're hanging mannitol, you really don't want to use a lot of it for that reason. So you have to limit the amount that you use.
Yeah, I think it's important to really be aware, like if you end up doing a cystoscopy and there's a bladder injury, then you really have to stop putting in the dextrose and mannitol, because you're putting a hypertonic solution into the bladder and you have to start draining it. If the bladder's intact, it's probably not as much of a concern that it's being absorbed, because after the cysto, you just drain it. But that's a really good point. So kind of thinking through all these agents and the different buckets they fall into, oral agents, IV agents, and cystoscopic fluids, and thinking about all the safety features, how do you decide which technique for each patient?
I think it's a good question, and the answer is we're not here to tell you there's one way to do it. And even when we've talked about this, we have little different things in the way we do things. I think you got to consider the surgical procedure being performed, what the patient's anatomy is, what their comorbidities are. What do you have available? I mean, there have been times when we were transitioning from sodium fluorescein back to indigo carmine, where we had sodium fluorescein, and I'd ask for something. And then finally I said to the OR, I said, look, I want to have this in the Pyxis. I want it available. And now everyone knows it's on my preference list. I think different physicians have different preferences, and that's okay. There may be cost concerns that you have. I think the agents and safety of it. And then the final piece of this is really just getting comfortable with the efficacy and the quality of visualization. And those are the things that really, I think, drive why you'll use one dye or one technique versus another.
Can you expand on that a little bit more? Like, how do you evaluate the efficacy and the quality of visualization? What does that mean?
Yeah. So, I think we all want to know that what we're seeing is actually, yes, this is efflux and it's good. And I will tell you that without fail, if you just sort of do the gut check and you say, look at a jet that is blue stained against a normal urine background versus urine against urine, it's much more clear.
Yes.
But in order to sort of do this, we ended up looking at IV indigo 10-disulfate or indigo carmine, and compared it to saline for visualization. So this was actually a multi-center study, randomized. So again, they were assessed, and the patients were given either 2.5 or 5. That was the randomization of indigo carmine, and the control was the observation of the ureter before they were given the dye agent. So videos were taken, and what we ended up doing beforehand is coming up with basically a score. It was called a conspicuity score. So it sounds funny, but it's looking and saying, like, one was, you can't really see anything, and 5 was like, wow, that's a striking, nice dark jet.
Obvious. Yep.
It was obvious, right? This is what you knew. And so independently reviewing these videos, and sort of each patient served as their own control, and then had some data behind the 2.5 and 5 ml. But it was very clear that the indigo carmine was more conspicuous, or a better agent, compared to just saline. And at some point you have to say, look, how much better, and is it worth it? Is it not worth it? I can tell you, there are no cases where I've ever regretted giving indigo. There have been nights where I've been a little more sleepless when they call me and say, hey, the urine output's low, and I didn't give the agent. So I think that the other thing that's nice about the study is we look at it, and this was specifically in gynecologic procedures. So, looking at the different types of patients, the populations of patients, and there were really no adverse events that were thought related to the indigo carmine. And so this, I would say, conspicuity score is what we ultimately use. And look, if you were really curious, at some point you could do a study looking at one agent versus another agent. But I think I was convinced that this is the agent for me. So at this point, I guess I'm going to take over the question asking, since you've asked me all the hard questions. Now I want to know, given what we've discussed, perhaps you can review a couple of patients to make this come alive for our viewers, and sort of tell me in terms of like your strategy to figure out patency. So this is a 65-year-old woman with a stage 3 uterine prolapse. She's undergoing a total vaginal hysterectomy with a uterosacral ligament suspension, an anterior pair, and a sling. So tell me a little bit about what you're going to do in order to evaluate this patient: when, how, why, what agents, etc. Walk me through it.
Perfect. So I think this is the perfect case to think through, because this is really the bread and butter for your gynecologist. It's a vaginal native tissue repair. But there are multiple steps to this procedure where ureteral injury is possible. It could happen during the vaginal hysterectomy. It could happen during the uterosacral ligament suspension when we put those high sutures in, potentially during the anterior pair, and also potentially during the midurethral sling. Really, the part that we worry about the most, this is a surgery that has a slightly higher risk of intraoperative ureteral kinking, and that's with the uterosacral stitches. So the literature out there suggests that there's an 8 to 11% chance that during the surgery, by just placing the stitches on both sides in the uterosacral ligament, we will kink off one of those ureters. And so that is really imperative that we catch it, and it gives us time to release it. So for this surgery, I want a very good agent, right? This is not one that I just accept, oh, you brought the wrong agent in, I'll just use it. No, this one I want indigo carmine. I really like it. So, and I actually cysto a few times during this case. So just talking through it for those of you who maybe don't do this procedure, but you do the vaginal hysterectomy first. And, my suspicion that I had an injury at that point is very low, and it's not urgent to detect at that point. So the next step is to go ahead and throw the high uterosacral ligament sutures in. And that's when I stop and do a cystoscopy. So more just for cost savings, and also because, as Ben showed on the previous slide, you can give half of the ampule, right? So one ampule has 40 milligrams or 5 cc's of indigo carmine, and his study showed that you can give 2.5 or 5, and you still have a pretty good, I never can say this word, Ben, but conspicuity score. And I find that true in practice. So usually I'll half the ampule and ask the anesthesia team just to give half of it, so 2.5, after I placed the stitches. And while I'm looking in, I pull the stitches on tension to really confirm and make myself feel good that those stitches are not kinking the ureter. If I really can't see it with a 2.5, I'm going to put in the entire ampule and give the 5 cc's. Then I proceed. I usually do an anterior pair. I tie down my uterosacral stitches. I usually throw the sling in at that point. And then at the end of the case, I repeat my cysto, because it's also possible that I missed the kinking because I wasn't pulling my sutures exactly the same way they tied up. So I usually throw the other 2.5 cc's in at the end of the case, repeat my cysto, and just confirm ureteral patency at that point.
Great.
Pretty
So
standard.
I think, yeah, really good example of using an agent, using sort of common sense to sort of say, hey, which step of the procedure when you do it. And I think that a good example of, how Cara uses the two doses. I think we were talking, and I usually just give the one. I find with Indigo now it lasts long enough, but not too long. I think the sodium fluorescein, when I was using it for this type of case, was always tough because then I would do the sling and I couldn't see anything because it was so darn fluorescent. But let's move on because we have about 5 minutes left to the next case. We'll try to get through 3 if we can. So this is a little bit of a more straightforward bread and butter case for you, I'm sure. 41-year-old patient with stress incontinence undergoing a TVT. So tell me a little bit about what you're doing for this patient.
Yeah, absolutely. So this is another bread and butter case, something that we do every day. It's a very quick 15-minute surgery, and compared to the prior case, the risk for ureteral injury is much, much lower. I mean, you can never say zero, but it's less than 1%. So, there are times that I will just hang normal saline, but every time I do that, I wish I had done something else because it's just sometimes hard to see, especially if it's the first case of the day and they're not
Right.
super dehydrated and their urine's not like very concentrated yellow. Sometimes it's hard to really convince yourself that you're seeing the ureter. And I believe that once you start looking for it, even though the risk is low, you got to see it. You've committed yourself to it. So I really like mannitol here. It's really easy to hang instead of the normal saline. I just hang 250 cc bags, pour it into the bladder, and the jets are very, very conspicuous, though I've never done a study to measure the conspicuity scale on that, but I think it's probably a 4 or 5. The
Yeah.
swirl is really beautiful because of the viscosity, the different viscosities of the fluids.
Yeah, and I personally don't do a cystoscopy on like a retropubic sling straightforward case, but at the same time, like would never fault anyone for doing it. And I think it's good. And if it helps you sleep, great. But it's nice to see you sort of use, a different agent that may be a little bit in a different way, just to sort of at least answer your question. And if you're going to look, to your point, you might as well look. I mean, I've been called by former residents that have placed slings, and then when they pull on the sling, they see the bladder move a little bit and they're panicked. Did I get the ureter? Because it can happen, right? That was not a 0 you had up there. And again, my answer as well at that point, we'll look for something if you were concerned. But I think that's a great case. And then maybe in the last couple of minutes, we'll just get to our third case here. So we have a 38-year-old patient undergoing a total laparoscopic hysterectomy. Of course, not by the urogynecologist, but by the minimally invasive gynecology team. So they're sort of, what do we do at this point in this case?
Yeah, so I'll start out maybe even by assuming that it was my case. That's fine. Hopefully not, but because it happens to all of us. So
no, it can, and I'm joking, and I'm just sort of. I think you're
but I will
right.
be calling you in a moment, but I'll get started and I'll let you know when I bring in the urologist. But so if it was my case, I probably have not given a PO agent. It's just not something I routinely like to do. I didn't mention it before, but I find that pyridium, it stains the mucosa of the bladder, and it also looks like blood sometimes, and I just don't like that feeling to not be sure. Why does my urine look bloody? Did we do something or did I get it? But here, if I'm doing a cystoscopy, I'm probably going to be giving indigo carmine, but maybe we haven't given it yet, and we're looking, and there's no efflux from the right ureter. So the first thing I teach my residents is time, right? Like you have to give even up to 20 minutes to let that ureter go, but you kind of know if it's not going, and you start thinking about, okay, which stitch is it that I have to go back and release? And then there's just certain things you work through. You can open up the fluids, try to hydrate the patient a little bit more. I will give the 10 of Lasix. I mean, we kind of go through these steps. Give the indigo carmine. And if you're seeing it like jetting repeatedly from the left and not in the right, then you have to go back and try to find out which stitch. And if you still have your laparoscope in, you can either start to remove them, because that's probably what it is. if you're really don't think that you've got this, like you go laparoscopically, you trace the ureter, you can even dissect it out. If you really don't think it's a ureter, you can stent.
Yeah.
And after that, I call urology for help. If I find a ureteral injury, you can come into my OR and put that together for me.
Yeah. So I think yeah, I was going to say it actually, even having given the agent, if it's not effluxing, and then you take the stitch out or you do something, and then all of a sudden you see it, it's like a much quicker, more surefire way of knowing that you did the right thing. Sorry about that. Okay. So at this point, I think we are hopefully not going to need a stent. You remove the stitch and you had efflux of some nice blue. I don't know that we're going to have a lot of time for questions, but I did want to thank the audience. Want to thank Cara. If there are any questions, certainly you can type them in, send them as you can.
I have two questions. Do you want to see if we can answer them quickly?
Sure.
I'll read them to you. So the first one, I'm not totally sure I understand it, but I think maybe. Do you use a time marker landmark for giving an oral marker agent?
A time mark, or so if you're using Peridium, how far in advance? Maybe usually, yeah. I would guess like an hour or so to 2 hours. I mean, that's part of the problem with the oral agents.
Yeah, I think Peridium you can give a couple hours. The riboflavin actually lasts even longer. Yeah. So at least for most of the surgeries I do, it should last through the entire case, even though I usually don't use it.
Right.
And then the other question is, I'm just trying to find it. How common, this is interesting. How common are opioids or SSRIs in your patients, right? This would stop you from using methylene blue.
Yeah, so I mean, I think they're very common, right? Opioids, hopefully less so now, but SSRI is very common. And that's why I think, when it had come up and someone brought it up, I think it was someone putting in an EMR and then there was a flag and then we had a whole discussion about it. But that there's in some ways no reason for methylene blue. Where I use methylene blue still is for retrograde installation of contrast. I don't know why I used that. Actually, the other day we were going to use Blue2Go or Indigo Carmine, and but methylene blue, it's really dark. It's this like easy agent. You mix it with some saline. The patient had a stent up. I flushed a little retrograde and pulled the stent out. I had the stent in for the case because we were dissecting by the ureter, and that's when I used methylene blue. So there, I don't worry about the serotonin syndrome, but a patient that is using an SSRI, I do worry about it, and that's why I don't use methylene blue now.
Yeah, and I think it's also, we don't have to worry about that with indigo carmine. So right. I'll be honest, there's some times in the case where you can't remember, and you can pause and go look up and remember if they're on an SSRI or just use indigo carmine.
Right.
Yeah.
Great. So, so I thank you so much for having us, and to the audience and the participation, the questions. It looks like there's a QR code for participating. You can scan the QR code to complete the evaluation and the CME post-test to earn your CME credits. Certainly, if there's some feedback, we want to know it so we can bring you appropriate programming and keep you guys interested. But want to thank Medscape Education as well, all the behind the scenes work to make us look good. So to Daniel and Jacqueline and the rest of the crew and Ann.
Yeah, and thank you, Ben, for all the talking and sharing everything you know. We appreciate it.
It's not much, but happy to share it. Have a good one, everyone.
Thanks, everybody.